I've been working with this engineering team, and I can probably share with you a little bit who is part of the team. Paul Fortier is my primary partner. He's a professor of engineering, and he's the one who's doing all the engineering development pieces. Professor Elizabeth Chin has worked with me on some of the clinical pieces, and we currently have 2 PhD students working with us, one from nursing and one from engineering. So this, as I said, is a long-standing project. We've had multiple master's students and undergraduate students over the years, and it was funded by a Provost Interdisciplinary Seed Grant. So I'm going to share with you and just tell you a little bit about the condition that I study, which is called heart failure, and I just want to sort of get rid of some of the misperceptions that you hear the word heart failure and right away people think it's a heart attack or that people are in imminent danger of dying with heart failure. It's actually a chronic condition that is the culmination of a number of different cardiac problems. And basically what's happened is it's the only cardiac condition that's increasing in our country because we've done such a great job of taking care of the acute cardiac problems like heart attacks. We treat hypertension better. So now we have many more patients with this condition called heart failure. And the reason I study it is it's actually one of the biggest areas that's growing in nursing. But my grandmother was my first heart failure patient when I was in high school, and she died my first year of nursing school. And she had said to me, promise me that you're going to do something because this is such a horrible condition. So I ended up continuing to practice in this area. It was personal for me when it started. Probably many of you in the room have family members who've had heart failure or have heart failure. As I said, it is a chronic condition, and the problem that people have with heart failure that I see as a nurse is they do have periods of exacerbation where they can be really sick and have bad symptoms, and then they have periods where they feel a little bit better and it doesn't go away. 6 million people do have it in the United States today. I did put my references there, and I just want to show you, again, to try and tie in a little bit about the sources that I go to. For me, I'm a cardiac nurse, and I know that my 2 prior colleagues really shared with you their point of view. So I guess in full disclosure, I'm probably an empiricist. I'm a home-based cardiac nurse, and I was one of those long-term critical care nurses, so you can see sort of where I came from. That's a little bit different than Stephen and Sharon. And my primary world has always been in the cardiac world. So the main sites that I go to, this is the American Heart Association site. And I think if anybody wants to do work in the cardiac realm, I would encourage you to tell students to go to this site. It's a wonderful site. And what they have on this site is not only data and numbers about who's affected by conditions, they have all of what we use called clinical practice guidelines. And that's something in nursing that's really important because it tells you this is the state of the science. I know someone had asked a question about why doesn't somebody identify the gaps and focus on those areas. This is one of the sites where that has happened, and they have clinical practice guidelines for all of the cardiac conditions that talk about this is the current research, this is how we're treating it, and this is what we do. But I also go to this site to find my updated numbers every year, and I'll just go down to show you that this Heart Disease, Stroke, and Statistics 2016 update is the first place I go with every single paper that I write and every publication I do. I go to that site because it gives me the current numbers for everything I need to know about heart disease. How many people have it, how much does it cost our country, what are the primary groups that have it, how are they treating it. And so I wanted to put this resource in there so that you could see this is the site that I go to. And then also at the top under guidelines and statements, if you click on that, it'll give you a whole link of searching for all the different kinds of guidelines with the different disease processes. And so as I said, it affects 6 million people in the United States. That number is rapidly growing. It's responsible for more than 1 million admissions and 15 million physician visits. So what does that translate into? It's really costly to our society to have this condition. It is the leading cause of admission to the hospital in people over the age of 65 currently, and that's the biggest group that we see. And again, I did highlight another site, the Center for Medicare and Medicare site, cms.gov, is another site that I often go to. It's specifically important to me for the heart failure population because, again, my group is primarily over the age of 65. There's really good resources on this site, on the CMS website. It'll tell me how many people have been admitted to the hospital, and there's all these different buttons that you can click that can say how many were admitted last year, how many people died in the hospital, And one of the big pushes in healthcare, as you see, because it's such a costly condition, is we're trying to reduce the readmission rates of this population. That hospitals are currently not reimbursed if somebody's readmitted with heart failure within 30 days of a discharge. And so for me, as a heart failure nurse researcher, when that happened a few years ago, when they passed that law, that hospitals would not be readmitted if they came back within 30 days with that condition, everybody suddenly became interested in my research area that I had been doing forever. And so people said, why are you studying that? Those people just die ultimately. But now they're interested because they want to know how can we improve the care of these patients. So again, this is a site that I recommend if you want to steer people. There's also research related to all the different areas that Medicare is doing and supporting. Again, close to 30% of people are readmitted within 30 days, and as you see, because it's so costly, $17 billion, they want to reduce that cost. Major symptoms include shortness of breath, fluid retention, and tiredness. And again, that really affects quality of life and their ability to live their lives. The other link that I did put there is, this is the Heart Failure Society of America. And basically, this is another multidisciplinary organization I belong to that's heart failure specific. And so there are organizations like the American Heart Association, which is all cardiovascular conditions. This is called the Heart Failure Society of America. It specifically focuses on the condition of heart failure. It's multidisciplinary, so we have dietitians, we have social workers, physicians, nurses, all kinds of disciplines come to the meetings. And this is another website that gives us the latest clinical practice guidelines specifically related to heart failure. They also come out with publications, and you can see the whole list here of all the publications, again, created by this organization. So this is the evidence in my area currently. And I can click on any of those to see what kinds of things I need to be doing for my particular patient population. And it's all based on the current research evidence that exists between the disciplines. I actually use it just to cite what the current symptoms are that you typically see in these patients. So just a little bit of background about my research area. So I do my research, my population is heart failure patients. I'm specifically interested in this concept called self-care. Again, you'll see a lot of nurses are interested in concepts as opposed to disease processes necessarily. And self-care really is just recognizing, interpreting, and treating heart failure symptoms. So it's the process of doing those things. Self-care behaviors, again, we undertake them so that the person can maintain health. And we know that research suggests that a number of factors influence self-care behaviors in persons with heart failure. A lot of times they fail to recognize their symptoms as heart failure. And even though I've been doing this research for a long time, it never ceases to amaze me that I'll have a patient who's had heart failure 2 or 3 years and will start having symptoms, and the last thing they think it is heart failure. And there's a lot of reasons for that. We found in the literature that age can affect it, cognitive status can affect it, and comorbidity. So the other conditions they have, sometimes they think it's something else and not their heart failure. The inability to recognize and correctly classify symptoms, again, can lead to delay in seeking treatment. So we're back to that money piece. The longer the wait, the sicker they are. They're probably going to be admitted, and they're probably going to be in the hospital a long time. So we want to try and minimize delay, because if they can be treated sooner in the process, they might be able to, in the outpatient setting, get a rapid medication and be treated and not have to be admitted to the hospital. The other thing that I alluded to and I wanted to share with all of you that's a big piece for me is I did talk about heart failure patients have a condition called mild cognitive impairment that goes along with it. Probably in 60 to 80% of patients, they do have some level of what's called mild cognitive impairment. Now, this is not dementia. Mild cognitive impairment basically are changes in memory, attention, and concentration. And so those are all skills that they need, again, to take care of themselves appropriately. So if they're having trouble remembering, did I take my medications? Am I supposed to eat this? They're having trouble with decision making, it can be difficult. And this is very new work. It was 2005 was the first nurse who started to identify it, Bennett, who's listed there, who's now Pressler. She's gotten married. And she's done the first work that sort of found that this is a condition that exists with heart failure patients. They don't exactly know what causes it. Mary Wu, who's a nurse researcher at UCLA, has done CAT scans on these patients and has found that there are changes in the brain structure. And then they also suggest that there's decreased perfusion to the brain, decreased blood flow to the brain, and it could be due to poor cardiac function, or they might have little blood clots that are preventing that. So that's something that was part of my thought process when I'm thinking, if I want to improve self-care, I have to consider this mild cognitive impairment piece, because that's part of it. And a lot of the research I was looking at, they were excluding those people from the studies. And I wanted to include them in my studies because they said, this is the real life person I see in southeastern Massachusetts. Again, information giving without the opportunity to practice self-care doesn't ensure learning. A lot of times what happens with heart failure patients is we teach them in the hospital, we tell them all the things they need to do, we send them home. Many of them do not get home follow-up. And so it's hard to learn self-care skills if you don't practice, and if you don't have the chance to recognize or practice with those skills. So I wanted to really look at that. And current telehealth strategies haven't worked. I was a visiting nurse for 15 years, and basically what would happen is people would get telehealth devices put in their home, and basically they'd weigh themselves, they'd take their blood pressure, and they'd monitor a few symptoms. That data would go back to the visiting nurse office. A visiting nurse would look at the data and say, oh, this is a problem, and call the physician's office. The physician's office would call the patient and say, I need to see you. Now, the patient never learned self-care because the doctor was always telling them, someone else was always telling them, come see me, I'm going to change your meds and things. And so, again, I'm coming from the perspective of I believe self-care is the patient needs to learn how to care for themselves, and they need to be part of the team. And that sort of is something that was touched on by two of the speakers this morning, that the things that we do as nurses that are so good is we do include patients as part of the team. I do use a model that guides my work, and this is sometimes one of the hallmarks of nursing work is we often have theories or models that help us think about how we're doing what we do. I happened to find this model when I was a doctoral student. It came out, and this woman, Barbara Regals at the University of Pennsylvania, has become my mentor now, and so I work closely with her. I use this self-care heart failure model, and it actually has two phases. And the first phase is called self-care maintenance, which is just the basic things that people do to stay healthy. They follow a diet, they take their medications, they exercise, they get a good night's sleep, they stay away from sick people. It's general things to stay healthy. What are the general things you do every day? The phase of the model I'm mostly interested in, though, is called self-care management, and that's all the green arrows. And basically what that is it's a process of recognizing your symptoms, trying to evaluate what's going on. Do I need to get treatment? Do I need to do something, or am I okay? Should I do something? And then evaluating whether the treatment worked. And so that's the phase of the model I'm housed in, and that's what guided this current study, is trying to promote that ability to recognize, interpret, and treat their symptoms. And then the self-care confidence sort of moderates that relationship, and the belief is that if you practice these skills, your confidence levels will increase, and those with more confidence will be better at doing it. It kind of makes sense. So the study aims for this particular study that I'm sharing with you is to see if people with chronic heart failure can improve their self-care decision-making by reviewing symptom patterns collected from mobile devices. And I also wanted to see, because a lot of people said to me, your patients aren't going to do that. They're going to be like, no, I can't do that. I'm not going to work with those devices. Because my average age in most of my studies is between 75 and 80. So that's not the younger people who are using the devices. So I wanted to see if it was feasible and acceptable for them to do this mobile symptom monitoring, actually implement it in the home setting, and see if they were able to actually do this. So the methods, as I said, I recruited people who had recently been hospitalized with an acute exacerbation of heart failure. I wanted people who were stable, had been discharged from the hospital, but still had the possibility of having trouble. So I didn't recruit people who hadn't been in the hospital in 2 or 3 years, because I wanted to make sure they're people who actually had something to monitor. and I recruited them in a local cardiac rehabilitation center. I did get IRB approval, and I did get informed consent from all of the participants. I did do some baseline demographic data collection, and so I did measure their cognitive status, and I'll share with you the instrument I used to do that, but I did want to know what was their cognitive status. Like I said, I was interested in including people that had mild cognitive impairment. I did look at their activity levels, and one of the things that I found in the literature, again, with heart failure patients is when their symptoms get worse, one of the things that they do is they do less activity. So they'll say to me, I'm not getting worse. And I'm like, well, how long did you sit in your chair today? 23 hours, and they only went to the bathroom. So it's like you'll see this gradual decline. So I wanted to know, are their activity levels changing? Because that's important to me, because if their symptoms are staying stable but their activity levels are really decreasing, sometimes it's a compensatory mechanism. You do less when you're not feeling well. I also wanted to measure self-care behaviors and symptom severity data. So I did collect all of that data on baseline because I wanted to have a baseline on all of my patients. And then I also, this was a 1-month intervention, so each patient participated for 1 month. I also collected activity levels and symptom severity data and weight using a cell phone app. So the engineers built a cell phone app, and I'll show you what that looks like because I have some screenshots that collected that data for the patients. And then I also had them wear a sensor device that collected basic physiologic data. And it has pulse and respiratory rate, and they're able to use some kind of an algorithm. I have no clue how this works, the engineers do it, and determine blood pressure from some of those measures for me. The EKG, we're able to look at their EKG tracing because I wanted to know, are they having arrhythmias or not, irregular beats. And then also patient activity levels. They actually put in, I guess they use it with orienteering, and it's a chip that's in the sensor that lets you know position and motion. So I'm able to see how much activity the person's doing, if they're upright, if they're down, if they're in the chair, which has been really nice. And that data was collected by the sensor daily as long as the person was wearing it. So it was continually collected, and that was being saved in a little chip in the device. Then at 1 month after I saw the person, I did also collect self-care follow-up data. Again, weekly visits were made to participants. It was me and Elizabeth Chin, who's my co-investigator, who made weekly visits. Both of us are PhD prepared cardiac nurses. We visited patients each week to collect the SD card that was in the sensor device. We answered questions. We monitored problems with the devices, and there were many in the beginning. I'll share some, as you'll imagine. And we also reviewed the cell phone app. And what I basically did is I would sit with the person at the visit, and I would have them go through and answer the questions while I sat with them, just to make sure they understood how to get through the screens and do it correctly. So I knew at least once a week they had data in the phone. And the study period, as I said, was 1 month in total, because I was really just trying to look at feasibility. Will this work? So the instruments I used to collect the data, I measured cognitive status, as I said. The gold standard is called the MMSE. I don't know if you guys have ever heard about that, but in heart failure, the gold standard is actually what is called the Montreal Cognitive Assessment Tool. And this is an instrument that measures, it basically measures attention, memory, concentration, and you get a score in each of those individual areas. So I can look if a person's having a specific kind of issue, I can look in the individual area, but the total score also lets me know if they have mild cognitive impairment or not. And I really just used it to look and see. The scores range from 0 to 30. 21 to 26 suggests mild cognitive impairment, and those with scores less than 21, it suggests dementia. I didn't include those people in my study because, again, I was concerned that they wouldn't be able to do the pieces. Self-care I measured with the self-care heart failure instrument. This is a valid and reliable instrument that goes right, it matches the components of the model. There's a self-care maintenance section, a self-care management section, and a self-care confidence section. There are questions specific to that. And the goal is you want to have scores greater than 70 in each of those areas. That's kind of what we're shooting for. Research has been done in the clinical practice realm that says if people have scores greater than 70, what we found is that their outcomes are just as good as being on optimal medications. So it kind of is mind-boggling. There's a researcher out in Oregon, he's actually from Massachusetts originally, and he did some work looking at survival curves, looking at survival, quality of life, and readmissions, I believe, and he found that people who scored greater than 70 in self-care management did better than people who were just on medications. So that combination of the two. So it's important, self-care management, he sort of paved the way for me to say self-care management is really important. Symptom severity was measured by the Heart Failure Somatic Awareness Scale, which basically just measures 18 common heart failure symptoms on a 0 to 5 scale. 0 meaning they don't have it, 5 it's really bothering me a lot today because I wanted to find out the person's symptom pattern. Activity levels are measured with the Duke Activity Status Index. It just gives me a basic energy measure for a day, how much activity the person's doing, and it converts it into metabolic energy equivalents. And then feasibility and acceptability was just qualitative diaries kept by Elizabeth and myself, my co-investigator, and then we gave each patient just a little notepad that they could write if they had problems with their devices when they were working with them. They would make little notes to us in these little pads. And then you can see the basic demographic variables we collected. So what is the sensor? This is my sensor. It probably doesn't look like what you thought. It started out, the sensor was actually, it was a big board when it started with multiple chips on it. And this was actually created on a 3D printer. And so the engineers in the lab created there's a little device inside here. And this is basically all of the little chips are inside this little box. And the patient wears it, it's a strap, it's like a Fitbit kind of strap. And I put some gel on here that, like they do with EKG strips. It's not very pretty, it's going to be smaller. The goal is, it started out like 8.5 by 11, so we've been 13 years. But the goal is to have it be the size of a quarter, and it would be put on the chest with a Band-Aid. So this is sort of one step along the way. And so the patient wears it around their chest. You can see, not always a good thing sometimes, but my patients, bless them, they all went along with it and did it. And basically they wear this, and there's a little chip inside here. This one's not in here, but there's a little SD card place where I just pop out the chip, put in a new one once a week, and I'm able to take that data, put it into the computer, and it gives me all of the information that I need on that. Now, keep in mind that I have heart failure patients who are elderly. This requires getting this around your chest, snapping it. The size can be an issue. Again, you can't be obese. So I keep in mind that I'm working with engineers, many of whom in their 20s. And they'll say, the first prototype is like, let's do this, this, and this. And I'm like, they'll never get that around them. So, it's been a sort of a lot with interdisciplinary going back and forth. But basically, that's what the inside of it looks like. Those are all the little components. It is a platform, which just means it's extendable, meaning we can add other components as we find other things that are important. Like in the future, sleep is becoming a big issue. If we want to add a chip that monitors sleep, they said that they could add this to that little chip. Of course, then they have to go back big and come small again. It's USB rechargeable, so there is a plug, and they plug it in each night when they take it off, so it recharges itself. I do have a 5-lead EKG position and motion sensor. It is Bluetooth capable, but at this time the device isn't able to transmit to a central site, and that is the next sort of phase of development. You can see we're going to keep PhD students busy for the next one. And the data is right now stored on an SD card. This is what it looks like when they collect it. We have so much data. Our original study, this study we just completed, had 10 participants who wore these devices 3 to 5 days a week for a month. This is a 10-minute strip of an EKG, a 10-second, strip of an EKG, pulse, respiratory rate, and activity levels. We have so much data from these people. And one of the men that was in the study was one of my participants. He was actively having chest pain and problems and went to the emergency room and left his device on. So I had all kinds of He ended up having open heart surgery afterwards. I said, we need to look at his data.
What's the sampling rate?
What do you mean the sampling rate?
How many times per minute does it take at that point?
It's continual. It's continuously collecting data, 24/7. As long as they have the device on, it's collecting data.
But is it every second, every millisecond, okay.
Like continually is, I mean,
It
so
must
like
be a
every
very, very good
millisecond.
sampling rate.
Right.
Yeah, it's a huge amount of data, yeah. So we have, like, as long as they have it on, we have every beat that they've had during that time. So that's the physiologic data. And again, I wanted the physiologic data because, again, the research literature suggests that people's perceptions of their symptoms don't always match what's actually going on. There are people who can be having some really awful thing going on and they're just like, oh, it's not that bad. And then you have some other people, minor things going on, and they're like, oh my God, this is the worst thing ever. So the cell phone application is really looking at the perceptual data. What's their perception of the symptoms or what's going on? Because I think that's the piece I may be intervening on, is helping them to understand and make connections between what's happening, when you need treatment, and how do you feel when that happens. So basically, the cell phone application, all patients were provided with a Nexus 5 cell phone with a data plan and this custom survey application. They could use the phone for other things too during the study period, but I did tell them whatever you do, we're going to have it, so we get the phones back. And basically, this is what the top screen looked like when they turned the phone on. They had just a welcome page. The DAISY was the Duke Activity Status Index, so they pushed that button and it opened up that survey. And one question at a time, it worked through the survey. The HFSA is the Heart Failure Somatic Awareness, which is their daily symptoms. They pushed on that, it went through the symptoms. I also wanted their daily weight, because remember I said one of the early symptoms of heart failure is their weight goes up. And then we also looked at dyspnea, which is shortness of breath, which is another one of those. So I had a rating scale for that. So we collected those two surveys on the cell phone app. And you'll see that this is when you go in, this is one of the questions. I felt discomfort or pain in my chest, and they would hit next. And on the right, you'll see where the tap to view response. So they would choose, I didn't have this symptom, it didn't bother me, it bothered me a little bit. One of the adaptations we made with our first patient, we had it on a 0 to 5 scale, which is how it was created. These are the words that go with it, but it was 0 to 5. And the first patient we had said to me, and he had literacy issues, he said, can I just have the words? I would prefer to pick the words because 1 or 2 or 3, I can't differentiate between that. So again, based on patient feedback, we made changes to the phone. And so you can see that they hit it and go to next. And it really doesn't let them mess it up. We made it as simple as possible. They can go back to the previous screen or they can go next and move forward to the next question. Components of the intervention again, monitoring perceived symptoms and activity levels. That was the cell phone app, so that's their perceptions of what they're doing. They did this, I asked them to do it 3 to 5 days a week. It took them maybe 5 to 10 minutes to get through the cell phone piece. It's relatively quick. And then daily monitoring of the heart rate, respiratory rate, blood pressure, rhythm, and all of that by the sensors. And as I said, the physiologic data, I asked them to wear the devices 3 to 5 times a week. I had some overachievers who had it on for 7 days. Some people slept with it. And they'd say, it's not comfortable to sleep with it. I didn't ask you to sleep with it. But basically, whenever they had their device on, the data was being downloaded into that SD card. Data basically were entered into SPSS. The engineers did whatever it is that they did. I didn't do anything with the raw data. They did something with the raw data. They converted it into an Excel file for me, and I put that into SPSS, which is the statistical program that I commonly use to do my analysis. I did do some basic descriptive statistics on all my demographic variables. I did a paired t-test because I was interested. Again, my first research question was, did self-care improve using this device and having them be thinking about their symptoms? And we also did content analysis about any of the device problems and what were their specific issues and things that were coming up. We kept them as the interventionists, and then the patients used their little notebooks to see what the issues were. And then this is just to show you my sample, the mean age. They were 67.7. That's a little young for my studies. That's not typically who I see. As I said, usually they're 75 to 80, but this is the group we had. They were a little bit more educated than I usually have. My mean educational levels usually 10 to 11 years. This group was at least all high school educated. Their MoCA scores, interestingly, remember that's the cognitive status. 21 to 26 is mild cognitive impairment. So my group was very highly, had cognitive impairment. 80% of the people in my study, again, I only had 10 in the sample, 8 of the 10 did have mild cognitive impairment. The other 2 were in the normal range. So again, that's the population who we're working with this disease. What you can see with the self-care maintenance scores, remember 70 is where we want them to be for adequate self-care maintenance. So at baseline, which is the one on the left there, it was 30.6, and it only went up to 31.05. I didn't stress about that as much because, again, self-care maintenance is those routine healthy behaviors people take, and I wasn't emphasizing that at all in this study. And self-care management started at 49.2, again, not optimal, went up to 63.9. That was a statistically significant increase, again, with just this 1 month change, that people were more likely to undertake those self-care management, which is the symptom monitoring management kinds of behaviors. And I took that as a really good sign because this was a very small sample. To get statistical significance with such a small sample I was very surprised. You'll see that 60% of my sample was male, 70% married, and most 80% living with incomes greater than $20,000 a year. The DAISY data basically suggested they had very low activity levels, even though these patients were attending cardiac rehabilitation. That was the only exercise they were doing. When I looked at even though they tell them walk at home, do all these things, this group was very sedentary. Another result that came out is developing a multidisciplinary partnership has been really wonderful. We each have our different languages that we use for what they call a domain or an ontology. It's very different for how I define something like that. I loved having patients as partners in the process. And I think, as I said to you, I came in with the philosophy as a nurse that I wanted the patients to be helping me develop this. What should the intervention be? What should the device look like? And I think that's what's going to help it to be successful and promote self-care because it comes from their perspective. It's not me coming and saying, this is what you have to do, this is what I want you to do. I had them using the devices, but they very much spoke up and shared with me the things that they liked and didn't like. Training patients to use the cell phone has been a plus. I did have one 82-year-old lady who didn't even own a cell phone, and I was teaching her how to use a smartphone. I had to make a couple of extra visits to her, but she figured it out and she did very well. Their patient input, as I said, changed how the instruments were developed on the phone because they would say to me, and we would change it right away with the engineer. So if we had 2 patients that we were collecting data on, as they were giving us feedback, we were changing the next version so that it would work better. 95% of the patients completed the intervention and used the devices for the full month, which suggested to me that it was acceptable and feasible in this group, which a lot of people said it's not going to work. Surprisingly, it did. Data collection, again, going forward with the sensor, we want to streamline it to eliminate the need to swap out the SD cards. And that's the next big piece, is to have it Bluetooth enabled so that it can go to a central site and we can actually use the data. And I started talking with some people in the computer science department because my dream, again, I started out as a home care nurse whose grandmother said, do this. And for me, I would like to see patients be able to turn on their TV and look at their own symptom patterns and sort of make decisions each day. And basically the computer scientist told me if they have a smart TV, which again costs a lot of money, so they have to get a lot of money, but if they have a smart TV, they could actually enter their data, download it, they could see it on the TV, and they could actually be making changes. And the way that we practice home care nursing would look very different if I went in and we looked at the patient's data and had a conversation about what they're eating, what meds they're taking, what symptoms they're having, when they should seek treatment. They can be making better decisions. So in conclusion, the findings suggest that patients did benefit from the symptom monitoring as noted by the post self-care management score. So that really for me was a surprise. I didn't think I was going to get statistical significance because it's very underpowered with only 10 participants. Also, it's useful and easy to implement in the home setting. Again, I thought about elderly people with mild cognitive impairment. Is this was ever going to work in a million years, and it actually worked. Again, it was a small sample, so with a larger group, I'm not sure. And also the thing that I liked is patients both with and without mild cognitive impairment improved their self-care scores. So I really like that piece of it, because a lot of the other work, they've excluded those people who, you know, again, I live in southeastern Massachusetts, so most of the people, 80% of the people I see are not the people you're seeing at academic medical centers in Boston. We have the 80-year-old elderly woman who lives alone on $20,000 a year with no social support, minimal literacy. I wanted something that worked with that population, so that was really my intention. And then always a pressing need exists to develop more innovative nursing interventions that help patients to recognize their symptoms. And I think that's something that's really important focus. As we know, if we can get people to adequate self-care management scores, they can have much better outcomes in the long run. So that's really my goal doing all of this. And I did include my references. I know librarians. Couple of things, and you'll see the heart stroke update, which I had showed you right at the beginning, the American Heart Association. But I did include them, and I just want to point out a couple of things again. Again, resources that I use probably on a daily basis as a cardiac heart failure nurse. And these are specific things that you might point people towards if they're looking for where would I find research on heart failure in particular. Heart and Lung is the official journal of the American Association of Heart Failure Nurses. So everybody who's a member of that organization gets it. It does focus both on clinicians' needs and researchers, and a lot of research on self-care is published in that journal. And so that's a really great journal to steer people towards. You'll see also Journal of Cardiovascular Nursing. And that journal is actually the official journal of the Journal of Preventive Cardiovascular Nurses. And so that's another journal. Journal of Cardiovascular Nursing is really where most of the self-care research in cardiac self-care literature is published. The woman who is the editor of it was actually developed the self-care model. So that's a lot of self-care is published in that journal. And then Journal of Cardiac Failure, that's down the bottom, that's Mary Wu, who I told you from UCLA. Journal of Cardiac Failure is the official journal of the Heart Failure Society of America, and that's interdisciplinary. You'll see a lot of medical articles in there, nursing, dietary, and I'm starting to see more pharmacy types of articles in there, but it's specifically, again, focused on cardiac. I'm trying to think if I have any different ones. So cardiac failure, those are the main ones. And as you see, I've got a lot of those in there because that's where most of the work that is of interest to me tends to get published. There are other journals too, it's just those tend to be the biggest ones. So any questions? Or